Good afternoon. Thank you so much for joining us. We really appreciate all of you being here today. And for those of you who are seeing it online, please know that you can reach us at any time. Before we get started today, we wanted to just take a moment to remember someone that we lost, who was a hero to our movement, and that's Larry Kramer. I wrote a story in today's NMAC newsletter about my experience with him. You know, Larry was one of those people who loved you and hated you at the same time, and who was the voice of our movement. And because of his strength and courage, he inspired a generation of activists and a generation of leaders who would ultimately be the people who are sitting at this table. I mean, I know that I am here because of Larry Kramer. I know that I am here because he wrote a piece in 1983 in the New York Native that talked about being mad as hell. And I was this kid. And I was scared, but I knew that if I was going to do anything, I had to fight that fear. And he set the tone for our movement. And so I know that we all miss him, and we are sad that he is gone. And so just let's take a moment to think of him. Thank you, everybody. So for those of you who haven't joined us, we're going to have a little technical assistance session right now before we get started. You will see to your right a box that says go to webinar control panels. In that, there is a section called the chat section. This is where you get to ask questions to us later on. But what we'd like to do right now as a way for you to kind of have some technical assistance is if you could put in the chat section your name and your agency and where you're from, and then Chip could start listing some of the names that come up. So please put your name and your agency and where you're from. And Chip, do we have any people responding?
Yes, we have Mallory Howson from American Exchange in Chattanooga, the first one. And still waiting for some additional folks. She's the first one. Ollie Sweet from, I'm sorry, hold on a second. Ollie Sweet from New Orleans, Sharon Novi from Ciccatelli Associates in Los Angeles, Michael Ruppel from the AIDS Institute, Sam Burgess from Louisiana Department of Health, John Holder from Health Merch in Miami Beach, Raymond Matta from the Friends Research Institute in Los Angeles, Lauren Orcas from Pennsylvania Department of Health. So we've got a lot on here from all over the country.
Great. Well, thank you all so much for joining us. If you are having any technical issues, please feel free to put your questions in there and Chip will get back to you. It will also be the place that you will be placing your questions when we get to that component of this webinar. If you have a question, in addition to your question, if you could put your name and who you are, it just helps us to, when we're trying to identify who's asking. And I think the final thing that I would say to all of you is, if there are any at the end of this webinar, there's going to be an online evaluation that will automatically pop up on your screen. If you could please make sure to fill out that evaluation, because as you can see, we're still learning how to use this format, and your feedback is critical and essential to the success of how we do this. So thank you for joining us today. I've invited two of my colleagues from the Partnership to End the Epidemics of HIV, STD, and Hepatitis to talk about a new initiative that the CDC is moving forward of giving $10.25 billion, and I mean billion, dollars to health departments to address COVID-19. And I wanted to have them talk about first this initiative from the perspective of health department folks, but also about what is the role that the HIV, STD, and hepatitis communities should be taking as this money starts to roll out? And how can we, if we want to, or if we feel it's appropriate, be a part of this initiative? So the first speaker is going to be David Harvey from NCSD, which is the National STD Directors. David, I got it wrong. National Coalition of STD Directors. I'm old, I'm tired, and David's going to walk us through a PowerPoint presentation. So take it away, David. Thank you.
Thank you very much. Welcome everybody, and I am gonna see where it is that Chip, I might need a little technical assistance with turning my slides on again. I don't see the, here we go. Hopefully you all can see my slides. Is that correct?
No.
Oh boy, hold on. Sorry about this, folks. Let's see.
I just want everybody to know that we did have a rehearsal.
So Chip, it's not allowing me to click on this button to share my screen. Did that work?
There you go. Yep,
All right.
there you go. We're also seeing a Pfizer webinar.
There's a Pfizer webinar going on right now about drug supply things. All right. Okay. All right. Great. So welcome everybody. Paul, thanks for that introduction, and I'm really excited to join you and Stephen for today's discussion. I think this is the start of a conversation with our community, and in many respects, this is taking very important stock of the current changed environment we are operating in our response to COVID-19. And this is also thinking very hard, critically and strategically about what ultimately will be a post-COVID-19 world, a very changed world for our public health programs. And so I think today's conversation can start us down that path. There are many questions and issues for us to consider as we go forward. And Paul, thank you for acknowledging the passing of Larry Kramer. I also think that it's very appropriate for us today to take stock of this very, very sad, somber moment of 100,000 deaths from COVID-19 and the terrible situations we are witnessing in Minneapolis and New York City. This is such a tough moment for our communities all across the country. It just makes sense to acknowledge that and to think about the implications of that for our work. We as a community are no stranger to out of control epidemics. We're no strangers to the social determinants of health and inequality. COVID once again is exposing that. Larry Kramer himself recently wrote a piece about it. So we have a lot of work to do ahead of us. So today, what I'm going to do is just touch very briefly on some basic information to make sure that we're all operating from the same operating level. So a little bit about what we're going to be calling as an acronym, the ELC funding stream from CDC, potentially the role that STDs, HIV, hepatitis, and I've added TB in here because of the historic role that TB has placed in contact tracing, dealing with respiratory diseases. I want to give you just the briefest of status reports on what's going on in contact tracing. And then Stephen's going to pick it up and really help guide a discussion today around community engagement strategies. What do we do with this information and what are next steps and how can we all try to join forces, collaborate, reach out to non-traditional partners as we think about this new funding stream. And last but not least, I just list some key resources on a slide, key things that everybody should know about as we go forward to think about this opportunity. So, as you mentioned, Paul, $10.25 billion has already been allocated to the states and directly funded cities through a mechanism called, it's a long name, the Epidemiology and Laboratory Capacity for Prevention and Control of Emerging Infectious Diseases, cooperative agreement. Now, to give you a little bit of context here, this is a cooperative agreement program administered by CDC that typically in the past has gone to public health labs and the epidemiologists, the lead epidemiologists in the state and in the states and cities. And so the acronym, of course, as I've already said, is the ELC Cooperative Agreement. That was funded previously at $260 million. Once COVID relief legislation passed and money was allocated from Congress in the first go around and the second go around, $620 million was put out through this mechanism. And then the third allocation of money is this much larger pot of $10.25 billion with a B dollars. One of the documents that everybody should take a look at is to see how the money is already flowing to states and cities. States and cities are getting tens of millions of new dollars. And there's an enormous question, of course, about how these funds can be tailored to local needs and spent in a way that responds to local community needs. These four things that are on the screen right now, testing, contact tracing, surveillance, public health infrastructure, these are all key aspects of the grant guidance. And so as states and cities respond to this request for how they're going to spend the money, they need to be looking in these major four areas about how they want to spend dollars. The first thing to keep in mind overall is that this is really an infrastructure funding bill. We all know this better maybe than anyone else, that public health has been long starved for resources. This is a down payment, an infusion of money to try to overnight increase the capacity of public health programs. And there's a role, of course, for community organizations to be part of this. So typically ELC, epidemiologists and lab folks, sit within infectious disease sections of health departments. Our communities of STD, HIV, hepatitis, TB, haven't always worked closely with this division. And hence, this is why at this moment, we really need to be thinking in new ways about how to develop partnerships and collaborations. And that's not universally true across the country, of course. But when you look at the past history of funding to this network, it's really not a lot of money. And so a lot of that money was spent on labs and very technical surveillance systems. This vehicle was chosen by CDC for very specific reasons. It was an easy, fast way of getting money out to the states. This program is regarded as highly effective. It's got a very strong management team at CDC, and folks who lead these efforts within the states are highly regarded. So this was a choice of CDC about how to put the money out to states. As many of you may know, Congress allocated money for COVID-19 relief. They added money to some HIV accounts at HRSA and other federal agencies. But when it comes to CDC, the money is allocated in really a lump sum to CDC. And so CDC had a lot of discretion to decide how they were going to spend the money. These are very key, important dates to keep in mind about what is going to be happening in the next couple of weeks. And so time is of the essence. Due tomorrow or is that today? Tomorrow or Saturday. Today's the 28th, May 30th. Initial plans for how jurisdictions are going to ramp up COVID-19 testing. Then by June 15, another plan has to be submitted for how testing will be increased for the next 6 months after that. And then the day after, June 16, is when work plans and budgets get submitted. So once again, as I already noted, what you can see here is that the funding, increases range from certain pots of money that are allocated to our tribal nations, and then money to the US territories, and then of course the states and directly funded cities. And here's New York City alone getting an increase of $807 million. That is a lot of money. So how can our community and our programs play a role? There's been a lot of talk, there's been media coverage of this. Some of you have seen the media work that NCSD the STD directors have been doing to call attention to our particular long history in doing contact tracing. Contact tracing goes way back decades in the United States, largely started prior to World War II in the context of syphilis. And from there, this effort has grown. I think contact tracing within the HIV community has a bit of a complicated history, and I'll touch upon that in just a moment. But these major areas are things that folks should be thinking about in terms of how a contribution can be made to COVID-19. So community-based organizations particularly are well positioned to offer testing, partnerships with communities, helping to educate, reach people, provide health navigation services. Contact tracing is all over this particular funding proposal, as is disease intervention specialists. Many of you know that within health departments, disease intervention specialists, this is a bit of a catch-all term, but these are very advanced, highly trained contact tracers. They're people who are not only overseeing contact tracing, but they're interacting with surveillance systems, contributing data, navigating people through the system. These are highly educated, specialized public health workforce, and these folks, of course, have been cut way back over the years. We think this funding stream is a great potential for increasing this workforce in addition to what's already going on around COVID-19 contact tracing. And then technology and informatics and surveillance infrastructure. We know these are enormous needs of health departments, so we expect a lot of money to be going to these areas. To touch a little bit more on the history of contact tracing, and we have been trying to tell the story of this in part to demystify contact tracing, but to also point out the differences between contact tracing for a sexually transmitted disease and what in the context this means for COVID-19. So contact tracing, obviously, in the context of COVID-19 is not about taking the names, notifying sex partners, names of people, but it is all about, of course, notifying, helping to educate people, navigating people, helping people to get to testing and understanding what isolation means around the context of a respiratory illness, COVID-19. It's the same skill set, but the demand and the numbers coming at this workforce are huge. And so local jurisdictions are really struggling with how to ramp up these systems. We think that with this particular funding stream, these are opportunities to further enhance this workforce and to think hard about how this workforce is also embedded in community. So community engagement strategies, Stephen is going to be talking about this, but there's three things I just wanted to remind folks. We have a very limited time to act. Governors and state health officers will be very important decision makers here, not just the leaders of the epi and lab divisions of the health departments. And I think from a community perspective, we have to think very hard about the role of community-based organizations, particularly reaching communities of color with competency and humility skills. These are very powerful things that we bring to the table. This is a slide that lists some very key resources you all need to know about. CDC is putting out things every day around contact tracing. NCSD joined with ASTO to do an entry-level contact tracing online curriculum that can be found at their website. Over 35,000 people have enrolled in this training so far. It is unbelievable. My own organization, NCSD, puts out daily alerts and all kinds of information on our website. Please check that out. And then the last one I wanted to draw your attention to is Vital Strategies. It's the group that's headed by Tom Frieden in New York City. They have they're just released a contact tracing playbook, which is very helpful information about how to design, ramp up, and support contact tracing programs. So this is my last slide. This is how you can reach me on Twitter and our organizational Twitter account, as well as my email address. Please feel free to contact me. We're willing to help out however we can. And so thank you very much. I'm going to turn it over to Stephen now, and I'm going to turn off my screen. So thank you very much.
Thanks, David. And Paul, and thank you and your colleagues at NMAC for inviting me to participate in this really important webinar. Let me confirm that folks can hear me. David, can you hear me?
I can hear you, Stephen, and my
Okay,
slides
perfect.
have gone off the screen, right?
Well, they have
No,
not.
we can still
They're
see
still
them
on.
actually.
You can still see them. Hold on.
There.
They're gone. Okay,
Okay.
good.
David, turn the camera off.
Turn mics. Okay. Thank you.
So, and David, thank you also for recognizing some of the challenges and experiences that we're having with COVID-19 and the really disproportionate impact it's having on basically Black and Brown communities. Not just are we being more infected by the virus, or many of us are infected by the virus, but in terms of deaths, Black and Brown individuals are also overrepresented. We're also in a time of just craziness in terms of how Black and Brown people are being treated. And this week we're seeing really crazy, horrible videos of the death of George Floyd. And so it's really important for organizations like NMAC to continue to really be the voice for advancing the health equity among minority populations. As a reminder, Nastad is a leading nonpartisan nonprofit association that represents public health officials who administer HIV and hepatitis programs in the US. We have a mission of ending the intersecting epidemics of HIV and viral hepatitis. And I realized I started out without actually introducing myself as Stephen Lee, the executive director for Nastad. And I'm new in my position. I started exactly about 3.5 months ago, so just before the COVID-19 crisis started. Nastad works through our efforts to strengthen domestic and global government public health infrastructure by advocacy, capacity building, and with a lens of through social justice. And our vision really is a world free of HIV and AIDS. I'm not going to repeat much of what David said in terms of the background on the $10.25 billion. The only thing I would add, David, is that their ELC also includes data and an investment in data systems and a collection of data and reporting of data for monitoring and surveillance purposes. So as I was thinking about this, I was trying to think really the resources seems to be flowing in as David pointed, in a fairly vertical fashion. And I think it would be really an incredibly missed opportunity if we didn't take a step back. The global public health infrastructure, support structure, infrastructure in the US, if we didn't take a holistic view of how these resources can actually be used to strengthen the public health infrastructure. As David pointed out, and as many of us point out on a regular basis, the public health infrastructure has been woefully neglected and underfunded over the past few years. So I can think of really 4 key opportunities for us in terms of how these resources can be further leveraged. So one is really the opportunity for the resources to support the establishment of a modernized public health surveillance system, right? It's not just that we will develop a system for responding to COVID-19, but we can expect that in the future, we're going to be having to deal with other infectious diseases. And so this is an opportunity for us to lay the foundation for strong, modern surveillance systems that can support surveillance of other diseases in the future. This is also an opportunity for us to leverage resources for existing state and local public health itself, the infrastructure of the public health system locally, but also for us to think about leveraging the resources for community public health structures. Over the years, over the past 20, 30 years of investing in the HIV epidemic, we've actually invested a lot. We, the US government, and many of us as implementing partners have invested a lot of time, energy, resources, man hours, work hours in also building our community public health structures. And so these are opportunities for us to really think about how we leverage the resources to build upon the community public health structures as well. And as David pointed out, this is also an opportunity for us to explore in strategic ways how to integrate across public health programs. So how are we integrating our engagement, relationship, partnership, collaboration, coordination, communication, all of those key words with our laboratory colleagues, our epidemiology colleagues, HIV, hepatitis, STD, TB colleagues, to think through and to really integrate and think of a holistic approach. And then finally, this is also an opportunity to address some of the workforce and capacity needs that we've really appreciated in the past 2.5 months, 3 months, seeing the challenges in terms of the public health infrastructure from a workforce standpoint. These are opportunities for us to think through strategically what are the types of individuals and skill sets that are needed, and then the number and quality of those individuals. One of Nastad's core values is really around diversity and inclusion. So we try to apply that core value in all that we do, whether we're talking about ourselves internally or whether we're talking about that with the way that we work and with the way that we design and implement programs. And as I mentioned, we've seen that the data showing the coronavirus and COVID-19 are disproportionately impacting minority communities. And so while the guidance that David talked about and the program that's being rolled out doesn't specifically mention HIV and hepatitis, we think these programs bring a tremendous amount of value to COVID-19 testing and the scale up of activities, particularly with regard to community-based testing, ensuring that there's equitable access to services among disproportionately impacted populations. So what I wanted to do is just present 4 examples of opportunities where I think we could leverage our work to support COVID-19 testing, and as David pointed out, the diagnosis, tracing, testing, and linkage to services and to programs. So one would be for us to think through kind of how do we engage, for example, the syringe service programs and syringe service sites to increase capacity to co-locate COVID-19 testing and to continue while continuing vital harm reduction services. And we believe that with adequate investment in testing capacity, in the PPE that's required, SSPs, I think, could become sites for COVID-19 testing and eventually treatment and vaccine co-location. I think ultimately, once there are treatments available and or a vaccine available, we could also explore how these sites become avenues for delivery of those services. Similarly, with appropriate resources, staff, the SSP staff, could play an expanded role in contact tracing or enhanced case management to support vulnerable populations and to engage in the broader system of social support and healthcare. And David, I'll add this to your list of resources after this, but CDC has shared and released guidance for how to safely operate SSPs during this time, and so there are opportunities for them to be classified as essential services for engagement in this response. The second one I would want to mention is around expanding home testing and the capacity across infectious disease programs for us to make available home testing. So health department programs are working currently to dramatically scale up availability of home tests. Some of this with support from CDC. CDC also recently released guidelines on HIV and PrEP self-testing strategies. So as COVID-19 testing technology evolves and for example, a home test becomes available, public health programs could work to ensure that there's availability of these multiple testing access routes and available approaches to accommodate, again, vulnerable populations. There may be ways for us to leverage home testing expertise and infrastructure across the HIV, STD, hepatitis programs, and the COVID and these COVID-19 initiatives. The third one I would mention is how we could utilize HIV and hepatitis prevention and education strategies to address COVID-19 access and outcome disparities. HIV and hepatitis prevention programs have developed unparalleled expertise in tailoring education, outreach, primary prevention activities to communities disproportionately impacted by HIV and hepatitis. And this includes young gay men, Latino men and women, transgender women, and people who use drugs. These networks and education strategies really provide an opportunity and a foundation for ensuring that these communities have the necessary information and access to services to curb the growing disparities in COVID-19 diagnoses and deaths. And then finally, the last one I would mention for us to think through and think about is, is to coordinate ELC testing and data collection with testing activities and testing and linkage activities that we already do through our DeWine Wright HIV/AIDS program and funding. The CARES Act also allocated $90 million to Ryan White grantees to increase their capacity to address COVID-19 related needs. And so there are opportunities to think about how we link, especially around not just testing and diagnosis, but the care component with ELC and with co-locating of services. So those are just some examples that, practical examples of how our community and our technical and programmatic leadership can be leveraged. So what have we done and what are we doing? David and I really think that this requires a multi-pronged approach to really demonstrate the opportunities and the capacities that our programs and our community can offer. We at Nastad, and I know David has, and I know Donna on her webinar for our TB colleagues have shared this guidance and this information with our members with the hope and intent of them hoping to influence some of the design and development of work plans and activities as this funding is being developed. But we've also worked to engage with association leadership of the epidemiologists, of the laboratory folks, APHL and CSTE. And I think ultimately David mentioned in one of his slides that the state health officers and governors are ultimately going to be the ones developing and submitting these proposals. And so we want to think about how we engage with that leadership as well. And then probably most specific for this conversation is then, and I'm hoping we can have some conversation around this, is then how we as the community-based organizations then get an opportunity to influence these discussions and these planning activities and work plans as well. As grassroots organizations, we have the experience in accessing marginalized populations, minority populations, and really making available, as David pointed out, the ability to build trust, build that connection, to build that human infrastructure for awareness and for the workforce build out that's going to be necessary moving forward. So I think I will stop there. And Paul, I think we are ready for questions from the audience. We can't hear you, Paul.
Still can't hear you, Paul. I'm glad to know I'm not the only one that's had problems.
You're not.
There you
You're
are.
not. There we are. So if you have any questions, what I'd like you to do is to put them in the question section of the box. And then what will happen is that Chip will be reading us those questions so that we can hopefully answer any questions that you have. Just a couple of things before we get started, though. For many of us, this is brand new. And I think there are some very, very important and difficult questions about how do we want to include COVID-19 programming with HIV programming. But the reality is that even if we don't get involved in COVID-specific programming, our movement is going to have to address COVID-19 as we look at how we provide HIV services, as we look at how we bring our staffs back to our agencies, as we look at how we continue to do the work that we have been doing. And so we are not going to not be able to address COVID-19. It's just the level at which we're going to be able to do it. That's the first thing. The second thing is, David, if you don't mind, can we put your PowerPoint presentation on our webpage with this webinar so that people can have your PowerPoint?
Yeah, please, by all means.
Great, thank you. We will absolutely do that. And the third thing that I want to announce, although I'm not going to announce too much, but I will say this. For this year's United States Conference on AIDS, we've added a brand new track. And the track is going to be about building COVID-19 services within the HIV organizations. Between the HRSA funding that just went out and between this 10.25 billion, and I repeat this, $1 billion, which I believe is probably the largest increase in health department infrastructure in our lifetime. There are both opportunities and challenges that our movement must address. And so with that said, Chip, do we have any questions?
We have an initial question. It's not really phrased as a question, but it's dealing with how CDC supports trans women in detention centers, particularly ICE detention centers, and how they treat trans women. They are sick, and had one, Roxana Hernandez, who died 2 years ago. I think it's just a question about, how we address that and how we deal with that. There's also a follow-up question. What is CDC doing to prevent this?
Well, let me say a couple of things on behalf of all of us here. Since none of us work directly at CDC, we only work in partnership with CDC. I can't tell you specifically about how CDC will respond. What I can tell you is that to all of the organizations here, the needs of the trans community are critical issues to our efforts, and that we are working diligently to try to address some of them. What I guess I would suggest to you is that if you could contact me later on, let's look at how we can get a letter to CDC that addresses your specific concerns. Next question.
Paul, could I just comment on that as well? Because I think it's a wonderful question. And, the person who posed the question, make sure that you read the guidance for this funding stream. And I don't know if there's a link in the chat or if it was sent out beforehand, but it's a 9-page document that states are responding to. It's not a long read. And what you will note in that guidance is that it talks about the prison system.
Yeah.
So the prison system, together with other networks, are eligible to receive funding under this stream. And as a community, we should be pushing to address the specific needs of trans women within prisons, and potentially, based on what jurisdiction or state you're in, there could be some money that flows to the prison system for COVID-19 testing and potentially treatment. And within that, advocacy can be done to make sure that trans women's issues are getting addressed within that system.
And Paul, can I just add something as well? This is not specific to CDC. Actually, it's not CDC specific, but at Nastad, we are about to release a document that is called Ryan White HIV/AIDS Program Part B and ADAP coverage of treatment and services for justice-involved people with HIV. So again, it's the beginning, potential beginning of a conversation where, again, this is HRSA funding, but the Ryan White Fund is funds care for individuals and care for individuals in incarcerated situations. We want to make sure that we are also supporting our trans colleagues in the prison system as well as part of this funding.
And Paul, it's one more segue. It's one more. There's one more. That's a segue to one more point that I wanted to make as well, because in the United States today, there is no federal funding stream that specifically supports STD clinics. It's one of the big tragedies, I think, in our field, and NCSD is working hard to change that. But until there is a federal funding stream for STD clinics, we're hopeful that this ELC funding potentially can support ramping up of COVID-19 testing and treatment, and using STD clinics that exist out there to reach people like trans women who we know may not be accessing free confidential services anywhere else. STD clinics are kind of a unique breed of provider out there. Often services are free, they're anonymous, they're confidential, they are a trusted source for communities of color. Boy, do I hope and pray we're going to be able to make some of these ELC funds flow to that network to ramp up their facilities and ramp up COVID-19 testing and treatment. So that's one more resource I think the trans community plus other communities should be looking at as a place to secure services and treatment.
David, thank you for saying that, because that's exactly why we're holding this webinar, is that I was very concerned that there is all this money that would be coming down the path, but that the HIV community, particularly communities of color, particularly disenfranchised communities like the transgender community, like Black women, like drug users, are not going to have the same access to these resources. And so I wanted to first just make sure that they were aware of this initiative. And this is the next question that I would ask you. What do you think the next step should be for the people on this webinar in terms of how do they get themselves inserted into this discussion?
I can have a crack at that. And then, Stephen, I know you're going to have great ideas, and Paul, you will as well. But I think that if there's one thing our community knows how to do, it's to create a ruckus. And in the name of Larry Kramer, this is a moment to, dare I say, act up a bit. First of all, rally with your local advocacy community, community-based organizations, and your advocacy organizations that are regionally and state-based. Two, review this grant guidance. Make sure everyone's educated about this money and how it flows and what it can be used for. Three, develop a plan for what you want to see, how dollars should flow to local communities, and potentially who might be the recipient of some of these dollars, and the kinds and specific types of services you want to see ramped up. And then four, take your campaign, request a meeting, make phone calls, send Twitter messages, emails, write first to the governor, then the state health officer, and then find out who the lead epidemiologist is and the lead director of your state lab system is within your state or city, and request a meeting, put forward a plan. It doesn't have to be really long. This is a very short, timeline that we have to accomplish this. And everybody on this call today knows what the local needs are. It's just a matter of putting it down in a compelling way on one piece of paper, sending it in, requesting meetings, doing phone calls, webinars, virtual meetings, and try to push for how money can be allocated through this funding stream.
Stephen?
No, actually, I have nothing to add. David said probably a
All right.
lot more eloquently than I would have been able to say it. Exactly what I was going to say. I think the only thing I would add is that um, my experience and the people others' experience is that our colleagues as epidemiologists and laboratory colleagues aren't necessarily familiar with some of our work and our programs. So David's charge of of putting stuff on paper, pushing, knocking on doors, reaching out. It's part of it is education and awareness, raising awareness to the individuals and colleagues who are going to be writing and pulling these plans together. They don't know us and they don't know about us, and so we need to get in front of them and make them aware.
Would it be fair to say that health departments, like a lot of other places, are fairly siloed, and that the epidemiology department may or may not be working with the STD or HIV or hepatitis departments?
Yes.
Well, I think, I think, not to speak for Stephen, but I think one of the reasons, Paul, we appreciated your invitation today to join you is that, we are struggling just like everybody else to adapt to the new COVID-19 world. Health departments are so struggling at this moment to not only serve real people, but also to invest and reinvent the public health infrastructure in a way they haven't had an opportunity to do in a generation or more, potentially. And because of how underfunded and under-resourced many of the systems are within health departments, and the way money flows, unfortunately, there's more siloing than we would want to see. So as we have worked with our members across the country, it's been challenging to hear the problems that folks have with some of these silos. So even though you may have two divisions exist side by side within a health department, because of all the constraints, the limited staff, the requirements of having to meet a funding thing, you would hope that there was more collaboration or partnership, but often that's not possible. And so we are, as I know Nastad is, working very hard to try to help folks think in new and creative ways about how to break down those barriers and think about how to partner in new ways. It is not an easy thing to pull off in this environment, but we have to sure as hell try, because this mechanism is how a lot of this money is going to flow now and in the future. And it's really going to require some very different thinking and approaches than we have employed in the past.
Yeah.
And because I guess the other piece, oh, go ahead, Stephen.
Sorry, Paul. I was just going to say, I'm going to pull my naivety card. I'm going to pull my rose-colored glasses card because I'm new to my role at Nastad. But exactly what you just said is what the opportunity is going forward, right? Is that we have been in such a siloed approach for years. The opportunity here is for us to integrate across the programs. And, as I was thinking about this, one of the phrases that came to my mind was a rising tide lifts all boats, right? That's a kind of an economic term that President Kennedy popularized in the 1960s. But this is a great opportunity of where the resources for COVID-19 can raise the boat of HIV, hepatitis, TB, and STIs, if we can think in a integrated and holistic manner.
Yeah, I was just going to say, and part of my other reason for hosting this call was because $10.25 billion is also a lot of jobs. And right now, I just saw that there are 40 million people unemployed. I mean, these numbers are just staggering. And so our hope is that for many of the people who may be unemployed, particularly people who, unfortunately may be in HIV organizations who have had a difficult financial time, that they can help their staffs pivot to some of these new jobs that will be coming up. As you look at this hump, I mean, are we talking about thousands of jobs with this money?
Oh, I think we're talking about thousands. I mean, looking at the contact tracing workforce alone, there are thousands and thousands of people currently getting hired, and it's a bit chaotic. And structuring this in a way that makes sense is going to be an enormous challenge for us in the future. And within the HIV community, there's been a love-hate thing around this focus of contact tracing for very good reason. But the modern day system, the way this is structured, it's called partner services within the HIV world. But make no mistake about it, there's classic elements of contact tracing within partner services, and those programs are embedded often, sometimes, in community-based organizations. So thinking about how to, to expand that work, how to be part of the contact tracing workforce is definitely one thing to be looked at. I also want to make one other comment, which is really kind of an interesting one to think a little bit about as we reflect on Larry Kramer's work and the history of our movement. But for very, very good reason, from the earliest days of the HIV epidemic, the similarities are so eerie with COVID. It's so disturbing. The racial disparities and inequalities of what's getting, what a bright light is shining on. But early on, the fight for our lives meant that we needed to invent our own systems, our own community-based organizations to save our lives. And that also translated into separate systems and funding streams, of course. COVID-19 is really bringing out into the light of day that we as a community are going to have to think in very different ways as we go forward about how to partner and collaborate in different ways, because increases in resources and dollars are not going to come, for the most part, specifically through HIV accounts, STD accounts, hepatitis TB. It's going to come in what we now are seeing as a lump sum of money to the ELC program, and it's going to require a level of strategy and collaboration that we may never have faced before. So there's a lot to think about here.
Yeah.
Anything, Stephen?
Nope.
So Chip, I didn't mean to ignore you. Are there any other questions?
Yeah, there's several. First, though, the person who asked about the detention centers also mentioned another woman who died in detention center, Johanna Medina Leon. I just want to make sure her name was spoken.
Thank you.
Do you feel it's appropriate for community-based organizations who are already doing HIV, STI programming and offer to help with the contact tracing and other COVID-19 related support, or should we wait to hear from health departments?
Oh, don't wait. Absolutely not. Act out, act up, call up, ask how to be part of the effort. Now, having said that, think hard about how to make that request and to be part of the initiative, because the contact tracing workforce, this is one of the things that we've had a hard time explaining through the media, because the American public, for the most part, doesn't understand how all this works and why should they. But contact tracing is kind of a unique entity of state governments, state public health departments, and they are empowered both by law and regulation to protect information, have access to surveillance systems, have access to electronic medical records. So one of the models that you see in the US today is that sometimes a partner services contact tracer type person will be embedded in a community-based HIV organization, but they're deputized by the health department, and they have to act within those laws and regulations for very good reason, to protect confidentiality. And so if your organization is already doing that work and perhaps already has an embedded, a type of person like this, and a relationship with the health department, by all means, you're very well positioned to expand those efforts. If you don't have that currently in place, think about how to be part of it, because one of the things that this guidance is really very clear about is that some of these funds need to reach communities of color, and they need to reach local communities, and they need to reach the people who are disproportionately impacted by COVID, which are Black and brown people. This mirrors exactly the problem we have in HIV. And so there is a major opportunity for community organizations that are working in this space, even if it's limited to some aspect of HIV and STIs, to be a part of this. So I would urge you on.
Yeah, I would just add to what David just said is to do your homework as well, right? So it's not just what you're going to propose, it's how you're going to propose it and to whom you're going to propose it to. So figuring out who within your local jurisdictions is responsible for the laboratory related activities, the epidemiology related surveillance activities. Often that stuff is on the local health department website. You can so that way you're targeting your efforts. Given this limited time frame to engage, you want to be able to target your efforts to the right people with the right information.
And use your allies, by the way. I mean, your HIV director at the state or local level, your STD director, your hepatitis and your TB director, you know, often they need to be armed. If you have a proposal or idea, go to them, tell them this is the role we think we can play. Help arm them in what they can do internally within health departments as well.
Yeah.
Great. Chip, next question.
We are having difficulty in reaching out to the EPI program concerning coordination opportunities with this ELC funding. Are there suggestions you can offer to help facilitate this?
So let me start by saying, and I really do appreciate Stephen and David being here and talking about the fact that this is a siloed world and sometimes it is difficult. Part of why I wanted them specifically was because I do think that the pathway for most community-based HIV organizations is going to be through their HIV-funded health department. I think that they're going to have to go to the health department component that knows them and works with them and can help them pitch this to the epidemiology division, because this also gives ammunition to the health department to say, listen, it's not us. We're being forced by those AIDS activists. And I don't mind having them say that, because we do need to be there, because the reality of who is getting COVID-19 and who is dying of COVID-19, we have decades of experience, and our experience should not and cannot be ignored. Next question. Oh, I'm sorry, David or Stephen, did you want to add anything to that?
No, well said.
Great.
Yep.
Next question.
Does the ELC grant include requirements to develop staffing plans for the possible resurgence of COVID-19? Is there any mention of having HIV, STD, TB staff involved in this planning?
Maybe not specifically in the way you just worded, but I sure would pitch it that way. Yes, we know that there is the direct work that has to happen with COVID, of course. COVID-19 testing, COVID-19 access to services, navigating the system, contact tracing, all that kind of stuff. But you will notice when you read the guidance that there's kind of interesting verbiage around improving infrastructure within the system. And I think really that opens up the opportunity to expand. And this is reason why we've been so focused on this in the STD field. The STD field is so under-resourced. It's crazy for the level of STDs we have in the United States. And so if these funding streams can be accessed and tied to COVID, it is an opportunity to expand what you're doing locally through STD clinics and through other services as a way of setting the stage to maintain those services once COVID lessens. We know, we're theorizing, there's been a lot of media coverage about this, that we're going to see resurgences in increased numbers of STDs, increased numbers of HIV and hepatitis, and that is really, really worrying. And and that's not even having the conversation yet about ending HIV. So we're very, very worried about where we're all going to be as a community when COVID lessens, because of the massive disruptions that have happened to the system and the lack of testing and the lack of access to healthcare. So we're going to have a whole recovery period after this is over that's going to require a lot of resources. Hopefully this can be one of the resources used in the future once this lessens.
Stephen.
The only additional thing I would add, and this is me putting on my primary care hat, you know, and again, beating this drum of integration and thinking about how, you know, if you're a patient and you come in and you're getting a COVID test, I mean, ideally you'd also want your provider to ask you additional questions. You know, what are your do you need an HIV test? Do you, are you at risk for sexually transmitted disease, et cetera, et cetera? So it's thinking about, I think, again, this is a great opportunity from not just from a testing standpoint, but also from a clinical care standpoint, for us to be looking at systems that are integrated.
Yes.
Well, thank you. Thank you all so much. It is 2 o'clock. We have been here an hour. I first want to thank the two guests. You know, I will say this publicly, but I will deny I've ever said this. I really do appreciate the partnership between all of our agencies. I think that we are so much stronger together than we are separately. But I do think we're better. But no, just teasing. But I say that to you to
I don't
say
know if I
that
agree with that,
part
Paul.
of what I think you saw here is just how smart and articulate are your national leaders. And I really want to thank them, because I know that some of the terrific work that is happening out there is happening because of their leadership. And so thank you all so much for joining us. This will be online, and look for next week's webinar, which is going to be about how to distance and reach your elected officials. Thank you so much. Have a good day.
Thanks for having us,
Bye-bye.
Paul.
Thank you. Bye-bye.